We have talked about how bone is built and how bone is maintained and how bone is repaired. Now I want to put in a little clinical connection that a lot of us will deal with at some point, and that is the bone mass loss that occurs with aging. Also, other things can add to the likelihood that it'll occur. I know you guys have all heard of osteoporosis, but I don't know if you've heard the other term. By the way, this clinical connection is in lots of your sets of notes. It's just me trying to make a connection to things that you will run into being a human, and also possibly introducing it to you even before you get to nursing school. And yes, if they're in the notes, they're likely to be on the test. Not every single clinical connection will be on the test, but they always could be. So let's look at what happens with osteopenia, which everyone is going to get. It's the bone mass loss that occurs with aging, and then osteoporosis. So let me show you what regular spongy bone looks like and then what osteoporotic spongy bone looks like. So this is a close-up of regular spongy bone, healthy spongy bone. This is osteoporotic spongy bone, as in porous, as in osteoporosis. Everyone gets osteopenia. You will have less bone mass as you age than you did when you were at your peak, and I'll show you some graphs in just a second. Not everyone will get osteoporosis. This is the loss of bone mass to the point that it starts compromising function and it starts having some symptoms associated with it. Among the symptoms, fragile bones, easily fractured. So if you're 30 and you fall down, you're probably not going to break your hip. But if you're 80 and you fall down, you very well might. In addition, some of the other symptoms are lost height, because the spongy bone that's in the bodies of your vertebra gets compressed. You lose bone mass and your spongy bone bodies of your vertebrae get compressed, and you will lose height. In addition, a lot of times you lose muscle strength, so you don't hold yourself up as well. In addition, you can also lose teeth associated with osteoporosis, but not because there's anything wrong with your teeth necessarily. Teeth are not bone, they're bone-ish, but really what happens is you should have learned about the sockets that hold your teeth in lab by now. They are little sockets that, so this is a tooth and this would be holding on to the tooth. They're called alveoli, singular is alveolus. And when they're nice and deep, they hold on to your teeth really well. But as you start to lose bone mass from your maxilla and your mandible, the sockets get shallower, and you can lose perfectly healthy teeth associated with osteoporosis. The humpbacked appearance a lot of times comes with the combination of the weak musculature and the compressed vertebra. So who gets osteoporosis? Well, any of us can. I don't know if you've had a bone scan. Most of us probably haven't had a bone scan. But they can detect hot spots where you may be losing your bone mass. But not everyone loses bone mass in the same way or at the same proportion. So let's look at it. Okay, so this is showing you a comparison just between bone mass acquisition and loss, primarily between men and women at different ages. So, of course, not surprisingly, most of your bone growth is, of course, you're accumulating bone mass. And you keep accumulating bone mass up until your, mid-20s maybe. And then around age 30, you can start losing bone mass. And with men, the bone mass is relatively gradual. And with women, it's relatively gradual, and then menopause can hit. And when menopause hits, you start to rapidly lose bone mass because, like I mentioned before, once you start using your sex hormones to build your skeletal system, you need them to maintain your skeletal system. And with menopause, there's a rapid-ish loss of estrogen primarily. And then after menopause is over, then the bone mass loss becomes more gradual. So who is affected by osteopenia? Everyone. As you age, you will begin to lose bone mass, usually around age 30 to 40. Now, if you're really active, you will put off bone mass loss for longer. Women will lose more bone mass than men, and they also had less bone mass to begin with. So notice that our peaks in males and females are not the same. That's not true of every single woman. There are certainly women with more bone mass than men, but if you look at women versus men as a whole, women tend to have less bone mass. And that's in part because testosterone causes more bone growth than estrogen does. But when women start losing bone mass, you can see that they lose it more dramatically, especially during menopause. They started out with less, and then on average, when they start losing it, they can lose up to 8% per decade, but males only lose about 3% per decade. Most of that loss is really in this dramatic area right here. And women, of course, had 30% less on average bone mass to begin with. They lose their estrogen really abruptly at menopause, and men taper off really gradually on testosterone to the point that, men can father pregnancies at 80 if they can find someone who's very young, much younger than 80, to have sex with them. So the real big loss is right here. They lose about 1% of their bone mass per year after menopause, which accounts for most of the 8% per decade. Okay, now there is also some ethnicity associated with it because not all ethnicities have the same bone mass to begin with. So if you look at a bunch of different ancestries, you will see that the likelihood of osteopenia and osteoporosis is not the same across multiple ethnicities. Caucasian women, white women, are more likely to have osteopenia and osteoporosis than, for instance, black women. And then Asian women are more likely than white or black women. Hispanic and Native American are very similar to one another. It doesn't have anything to do with skin color or anything like that. It's basically just these population genetics predispositions of different ethnicities. But it's good to know that your ethnicity can predispose you to certain pathologies. And it's good for individuals to know that, both in taking care of themselves and also in looking for more likely outcomes for people of different ethnicities as a caregiver. Okay, the other thing that also matters is that your body size does matter. Tiny women had less bone mass to begin with, and they are also not doing as much weight-bearing activity when they're carrying their little selves around. Big women had more bone mass to begin with, and the weight-bearing activity of carrying themselves around helps to maintain their bone mass, because when you stress your bones in gravity, it helps them to activate osteoblast activity and decrease osteoclast activity. In addition, being very, very thin, especially after menopause, estrogen is derived from lipids. Fat tissue is a source of estrogen after and during menopause, and very, very, very thin women can actually stop producing estrogen altogether. And you've probably heard of that in those extreme situations, like you've got an extreme elite gymnast with very, very low body fat percentage. She may also stop menstruating and stop ovulating. And eventually that will have an impact on her skeletal system as well, or for other reasons. For instance, if you have someone who's suffering from anorexia, very, very low body fat percentage can stop estrogen secretion, stop ovulation, and also start to make you lose bone mass. So you can end up with a 20-year-old with the bone mass of a 70-year-old with a massive, massive loss of your body fat. Okay, so is there anything that you can do to prevent this? Well, yeah, stressing your skeletal system in gravity helps to maintain your skeletal system. So it's use it or lose it, like it is with muscles. Exercise to stress your bones. Walking is fantastic for your spine and your hips. You don't have to do anything that's outrageously hard on your joints to get the benefits to your skeletal system. Weightlifting is fantastic for your upper body. And don't worry, women tend to worry that they're accidentally going to get super buff. Nobody accidentally gets super buff. Serena Williams put some work into that muscle mass. So swimming is fantastic for your cardiovascular and respiratory system. It's really good for your muscles. It's not quite as good as you would imagine at maintaining your skeletal mass because, of course, the water is taking some of the stress off of your skeletal system. The other thing that's important is to maintain adequate nutrition. You need good calcium in your diet. You need vitamin C and vitamin D for absorbing calcium. You also need protein in your diet. And then for reasons that are really difficult to explain, smoking is absolutely abysmal for your skeletal system. It's bad for lots of things. That's one of the things that it's bad for. And then what about a woman who is trying to avoid this symptom of menopause or some other symptoms of menopause? Sometimes women will choose to do hormone replacement therapy to stave off some of the symptoms of menopause. And that's something to discuss with your physician because people with certain genetic predispositions to, for instance, breast or ovarian cancer, hormone replacement therapy may increase the likelihood, but people without that genetic predisposition, it may be a good treatment for them. Okay, sodium fluoride, calcitonin, that same hormone we talked about before, the one that tones down your calcium by making it deposit into your bone mass, that can be a treatment here. And then there's something called alendronate. I think it was sold as Fosamax. That is one of the few drugs that can actually help to reverse the bone mass loss. Okay, in the next video, we will switch over to chapter 9. We're still going to be talking about bones, but we're really going to be talking about joints. Okay, and that will help us to hook into the next topic, which is going to be the muscular system.